Hey everybody, I'm going to try this for the third time. I'm recording to my computer, not the cloud. I hope that works. I also got vaguely distracted by downloading lots of Zoom backgrounds. So this is my newest one. This is where I'd like to be right now. I am not. All right, so let's get started with drug-drug interactions. I guess first and foremost is what you're going to use for drug interactions. I tend to use Lexicomp. That's just the one that I kind of got a lot of experience using when I was training. So that's my go-to. Micromedix is probably just as good. They are technically two different databases. So if you're dealing with patients who have lots of drug-drug interactions, so for instance, I was working in an HIV clinic in residency for 6 months. And in that scenario, we would run both Lexicomp and Micromedix on every single med list that we got. To be sure that we didn't miss anything, because sometimes the way that they report those back is vaguely slightly different, and it might make you just kind of reconsider something. So if you're not super familiar with a drug interaction, it is always nice to run it through the opposite database just to get a sense as to how they interpret things. So I'm going to go ahead and share my screen and show you what I use for Lexi and like what I'm thinking about when I go through this. So I snagged a medication list from one of the IGEP patients. Subsequently deleted it, but basically the patient was on, when you go to Lexicomp in pharmacy library, so let's go there now. So go to pharmacy library, obviously drop down to Lexicomp. Once that loads, you're going to go to interactions here. Start typing in your drug names. So I had a patient on aspirin. Evidently that's not how you spell it. Aspirin. Anyone? How am I not spelling this right? Aspirin. Let's try atorvastatin. Yeah, okay, something's wrong with Lexi. Hold on. Aha, I got logged out. Explains it. Hey. That's also wrong. 1 minute. Okay. So while that loads, a couple other databases you should know about when you click on them. Why don't I go ahead and launch Micromedix on top of this? So beyond those two, Consumer Lab is another one that I've been using lately, as well as Natural Medicines for some of your drug-drug interactions. Okay, so I've got Lexicomp loaded up here. Now let's try aspirin. Great. Statin. I'll say Lexi's been getting on my nerves lately with its autofill. It's kind of annoying. So metformin. We had lisinopril. There was glipizide. There was empagliflozin. There was nitrofurantoin. And let's see, there was another. So I typed those all in, and frankly, it was kind of a random order, but that was pretty similar to the way that the drugs were listed. So the first thing you should do when you're getting a drug list from a patient is think backwards like a pharmacist. Any pharmacist that sees a medication list should be able to see a medication list and come up with a problem list off of it. Pretty simply, we're kind of working backwards, right? So already off the top of my head, I know that this patient has diabetes, right? Probably type 2. Pretty significant because he or she is on 4 meds. They either have hyperlipidemia or are indicated to have statin therapy for ASCVD risk. I see aspirin. It's probably 81 it was 81 milligrams on the list. So I'm asking myself, has this patient already had a cardiovascular event? Is aspirin on board for secondary prophylaxis? Or are we trying to prevent a cardiovascular event? In which case it would be on board for primary prophylaxis. So that's an important question to understand. because it helps us decide whether or not aspirin should be kept or not when we look at this from a Beers criteria. What else do I see when I just look at this med list here? I also see that this person seems to be having trouble with frequent UTIs, and they're on nitrofurantoin. So we also know that that is pretty, it needs to be renally dosed, and I don't love the idea that someone's constantly getting UTIs. So I might want to look into that a little bit more. And I'll give you guys like a little teaser. You should be thinking about this from a global picture, maybe not for the IGEP experience, but certainly when you're out on APPEs and you're looking at a patient's list like this. There's a medication on this list that sort of has a side effect that overlaps with an indication here. So as you're putting everything together, you sort of want to be thinking about those things. Okay, so let's call it good for now. I'm gonna add actually two more. I'm gonna add red yeast rice. So a lot of patients were taking that. I'm also gonna add, let's see if Preservision doesn't come up. Let's do multivitamins. And we'll do it with iron, but it's a good, a lot of people had multivitamins but didn't have the type. It's a good idea to at least try to follow up and see, is there iron in it or is there no iron in it? Because remember, iron could be a chelating agent and have an impact on absorption of medications. Okay, so then we're going to go ahead and hit analyze. And, you know, you get this nice kind of filter, which I kind of like. You can filter by drug, you can filter by risk. For now, let's just stick with all of them. So obviously X is the worst, and you really shouldn't be tolerating any X's here. When you click on it in Lexi, you get a nice description of what's going on. So you get your risk rating and then the summary. So of course we're going to start here. So red yeast rice may enhance the toxic effects of HMG-CoA reductase inhibitors or statins. It's a major interaction and it's fair. So that means the severity could be pretty significant. And then fair means that there's some data, but not a ton. So, you know, take that with a grain of salt. Generally speaking, I don't like having anything that's an X-rated interaction here, and I'd like to understand what's going on. So you can go to what you should be doing for your patient and how to monitor it. And we see that, you know, basically avoid concurrent use. Any patient using this combination should be followed extra closely for signs and symptoms. So this is not like the drug interaction will kill you, but we are at much higher risk of toxicity here. And let's try to understand why. So red yeast rice is a natural product, contains several different compounds that are structurally similar to statins. This one, the monocolin K, is identical to lovastatin. So basically the patient's taking two statins when they're taking red yeast rice and any other statin. Now the question is, like, how much lovastatin would they be getting in red yeast rice? And because red yeast rice is a natural product, it's not regulated by the FDA. So the total quantity is unknown. So we kind of read through here, and similar to muscle toxicity with statins, we find that there's data of several case reports describing myalgia and myopathy related to the use of red yeast rice. So there's at least case reports here that this has happened. So it's not like theoretical. We have documentation that it occurred. And then the problem here is that the concerning issue is that combinations with red yeast rice, there's large variability, which is sort of what I was talking about here. According to one study, total content varied between 0.1 and 10 milligrams of lovastatin per capsule. So that's like a, you know, easily 100-fold difference in concentration. It's very hard to predict. So when I'm reading through these high-level drug interactions, I do honestly read almost all of this because I really want to fully understand what's going on before I decide what I'm going to do. So in this case, I'd probably be talking to the patient and say, you know, you're already on atorvastatin. It's a fairly potent statin. You're not deriving a significant benefit from red yeast rice, and you don't have the confidence in knowing that you're consistently getting the same amount. So I'd suggest discontinuing it. All right. Let's move into our Ds then. So just right off the bat, I can see that since I've already thought about what drugs I have in their indication, I'm getting level D interactions with glipizide, and these are all my diabetes meds. So I can predict that it's probably hypoglycemia. So, we've got two medications that are trying to cause lower glucose levels. When you use them concomitantly, you're going to get a reaction here. So, major reaction because it could be severe. Hypoglycemia could be life-threatening. Reliability rating is fair. So we don't have a ton of reliability here. And let's go down to the discussion to see why. Manufacturers of all SGLT2s warn that the incidence increases when co-administered. It's recommended that sulfonylurea dose reductions are given. So we don't even have case reports. It's basically the manufacturers are all like, we would be fools if we did not warn you of this. And we can see that it's pretty much a class effect here between all of them. So of course, this patient's already going to be monitoring for hypoglycemia. I would probably let that ride. And, it's a level D, but we're monitoring for hypoglycemia. Similarly, same thing here. TZDs are going to enhance the hypoglycemic of sulfonylurea. Again, major and fair. And here we actually have some detailed studies. So in a 16-week study of pioglitazone plus sulfonylurea, the rate was 3.7%, compared with 0.5% for sulfonylurea alone. So that's pretty high, right? That's a much higher incidence of hypoglycemia. We also have this patient on metformin on top of everything else. Now it's not interacting at a level D, but this is a patient, we're adding on levels of risk here where we've got multiple drug interactions that could cause hypoglycemia. I'm looking at this patient and recognizing they're not getting adequate A1C control here. If this was somebody you were seeing in the clinic, this would be somebody that you'd probably want to pull in and do some really targeted therapy. Since this is somebody that we're seeing in IGEP, we don't have the ability to really connect with their physicians. I think the most important thing you can do here is counsel them about what does hypoglycemia look like. Do you have glucose tabs on hand? How long have you been on these? Maybe at just helping them ask their doctor, are they getting any benefit from maybe, let's say, pioglitazone anymore? Do they need to be on it? It's not a great drug. Obviously, they were just started on a brand new drug, which is empagliflozin. So let's see how that one's working. Now, that said, I'm going to circle back to something that I said, which is empagliflozin, SGLT2 inhibitors. That has one of its major side effects is can cause UTIs. And we noticed that this patient's taking nitrofurantoin for UTI prophylaxis. So I guess my question is, has he or she ever had a UTI on empagliflozin, or was this preventative? Like, what's happened? And maybe just dig into their story a little bit. Did they start getting UTIs when they started empagliflozin? If that's the case, maybe an SGLT2 is not the way to go. Maybe a GLP-1 is a better choice here. So I highlight this because you're not going to get that kind of an interaction on any drug-drug interaction screening because it's more of a drug-disease interaction. That's the value of the pharmacist, is really being able to say, oh, you know what else I know about empagliflozin? It's this side effect. And I happen to see a drug that's treating a potential side effect of another drug. Well, that's foolish. Are we making the right choice here? So that's X. Those are level Ds, and then also thinking about drug disease type interactions and how these things might overlap with each other. Okay, so then we're going to get into all of the Cs. And interestingly, I see depends on dose, depends on dose, depends on dose for all of these. So, sorry, it's a little bit late. Not really, it's only 8 o'clock. All right, so let's look at the multivitamins and see what we see here. Impact of aspirin on ascorbic acid has only been demonstrated with aspirin doses of 600. All right, well, we're giving aspirin 81. Probably not going to have an effect here. I'm not going any further. Aspirin and empagliflozin. Again, I'm seeing salicylate doses of 3 grams or more is likely only of concern. Okay, I'm giving 81 milligrams. I'm not even remotely close to that dose of 3 grams. Probably not likely to happen. I'm a little curious because empagliflozin is a new drug and I don't know it as well as I know other meds. So sometimes when these happen, I, just for my own education, I'll read through and see what's going on. And it's salicylates causing hypoglycemia with an agent that causes blood glucose. So it's a hypoglycemia risk. And again, it's at 3 grams. So I'm not particularly concerned about it. And I was just kind of reading to better understand what's going on. Okay, so ACE and lisinopril, or aspirin and lisinopril. This is not a depends on dose. Let me just click this for consistency. So 3 grams again, not one that I'm worried about. Now this one does not have a dose recommendation here. So it is ACE inhibitors and salicylates, monitor therapy. Salicylates may enhance the nephrotoxic effects of ACE inhibitors. Salicylates may diminish the therapeutic effect. So we kind of know this, right? We know that that NSAIDs or salicylates, aspirin being within this same class, and ACEs both affect our renal perfusion. We've talked about this a couple times in IGL and the renal module. And so that's not uncommon. So it's a moderate. So this is not severe, or it's not like severity high. It's a possibility, and reliability rating is fair. And there's some case reports or data is inconsistent. So this is more like, I won't say it's theoretical because we have studies here, but it's really just talking about the potential for aspirin and ACE inhibitors to decrease kidney function and the potential for aspirin to have antihypertensive effects. So, in that scenario, in the antihypertensive effects, I'm looking at that study, and it was aspirin of 300 that resulted in a decrease in blood lowering effect versus aspirin 100 had no effect. So I'm not super concerned about aspirin impacting my blood pressure at a dose of 81. I'm also probably not that concerned about 81 milligrams of aspirin and an ACE inhibitor affecting renal function. But, I'm just going to kind of keep it in the back of my mind. This patient does have an ACE on board. They are taking aspirin. They have metformin, which can cause lactic acidosis if you lose your renal function. And if I'm being honest, this person also had ibuprofen as a PRN, which I didn't put in this thing. So, they're doubling up on an NSAID in that scenario. I would just, be talking about making sure that this person stays well hydrated. Another thing is empagliflozin can cause AKI if the patient's dehydrated. So add that up with all of these other things related to this interaction. And we just want to be sure that they're aware of what to look for if they were to lose renal function. So if all of a sudden they stop urinating, or they're getting hyperconcentrated urine, they're beginning to feel dizzy, those sorts of things, or they're dehydrated, I would, have them touch base with their doctor. And, if they were taking ibuprofen, definitely counsel them to probably not be taking that. Okay, so the rest of these are all the aspirin dose effects. Here's our glipizide and metformin, and it's probably hypoglycemia risk. Yes, of course, anytime you're on 2 diabetes medications, you're going to have a hypoglycemia risk. Fine by me. Lisinopril and metformin. ACE enzymes may enhance the toxic effects of metformin, risk of hypoglycemia and lactic acidosis. Moderate, and then reliability is poor. Okay, so poor. So it's not consistent. I don't really have much data here to suggest that this would happen. The degree to which ACE inhibitors contribute to an increased risk is unclear, but closer monitoring is prudent when possible. So this is getting back to what I was talking about before, where you have an ACE on board and you have a medication that's renally eliminated. You just want to be aware of that. You want to be sure that you're not putting this patient at risk for any potential complications by impacting their renal function substantially. All right, so that is Lexicomp in a nutshell. I can type these all into Micromedix as well. Let's see if we get anything different. I have to say, I like the autofill on Micromedix much better. pioglitazone, and pagliflozin. We had orvastatin. I already put that in. Let's see if they have red yeast rice. Yes, they do. What do they have for multivitamins? Wow. They have almost all of them. Awesome. Wow. So this could be potentially overwhelming on top of that. Let's just pick multivitamins with iron. Let's see, what else am I missing here? We had glipizide and they get nitrofurantoin. So Micromedix does it a little bit differently. They're listing severity and then level of documentation here, and then summary. So whereas this aspirin glipizide interaction on Lexicomp, let's see, aspirin glipizide was a level C, and it said depends on dose, and I wasn't very concerned about it. When I see this, I mean, honestly, that kind of freaks me out a little bit when I look at it. So I'm going to go in and click on this and see what we see. May result in increased risk of hypoglycemia. Effectiveness of oral hypoglycemic drugs may be increased with concomitant use of moderate doses of aspirin. This may lead to hypoglycemia. Monitor sugar carefully. So this is all we get here. So I'm not loving this. Also, what a weird reference. It's coming from the Yosprala, this combo med, as a package insert. That's such a weird reference. I mean, that's probably why the documentation is fair. I don't love this because maybe it's just because I'm used to Lexicomp, but that didn't give me nearly as much information to make an informed decision as this did when I went and I clicked on this, and this is telling me it's really only when you're concerned about 3 grams or more, and I'm looking down here. Salicylates 3 grams or greater have been observed to enhance blood glucose lowering effects of sulfonylurea. And then they give me all of these citations here, particularly up to 6 grams daily. Wow. So yeah, so Lexi's got a much more robust reporting on this interaction than Micromedix does, in my opinion here. Let's do the pioglitazone. I mean, all of these are going to be glipizide. Pioglitazone is going to be hypoglycemia, increased risk of hypoglycemia. Severity major, documentation fair, summary. That's it. So you don't get a lot of the patient management stuff that I'm seeing in others. Now let's see, atorvastatin, pioglitazone. Did we have that here? I don't see that as an interaction here. So what's this telling me? Atorvastatin and pioglitazone may result in decreased pioglitazone serum concentrations. Monitor blood glucose concentrations if atorvastatin is added or withdrawn from the treatment regimen. Dose adjustments may be necessary. Concomitant use of atorvastatin and pioglitazone may decrease pioglitazone concentrations in healthy subjects. Administration of 40 milligrams plus atorvastatin 80, okay, elicited reductions in the Cmax and AUC by 31 and 24% respectively. So that's pretty significant, a 30% reduction and 25% reduction. Now that's with max dose of atorvastatin. I know that this patient was on 40 milligrams of atorvastatin, so I don't expect that. But that's good to know. And also Lexi did not tell me that that was a drug interaction I should be thinking about. So again, this is one of the reasons why we did run them on both sides here. Let's see. I have an empagliflozin lisinopril. This is the ACE and the hypoglycemia. All of this is coming from package insert material here. Fair. So I think that gives you kind of a good understanding of sort of the differences in the drug-drug interactions and maybe why I end up preferring one over the other. Here's the lisinopril metformin interaction. Again, it's just sort of giving blanket statements from these package inserts. So I'm not particularly impressed with Micromedix, but I will say Micromedix picks up this as a drug-drug interaction, whereas Lexicomp did not. So I'm kind of surprised by that. So that's a pretty good rundown of drug-drug interaction screenings, and hopefully a little bit of an indication on drug-disease interactions. The last two things I'll briefly show you are natural medicines. I might not be logged in after that whole process, so I already loaded this up, but you can search for any natural supplement in natural medicines, and it gives you this great background on what the product is, why they believe it to be effective. This says in the US, the FDA considers red yeast products that contain significant quantities of these statins to be unapproved drugs. So another reason why I have issues with red yeast rice. It's also known as, so you get all these different things. What I love about it is it tells you like what is it commonly used for. So it helps you understand what there are many different indications for natural supplements. But also, you can jump straight to safety, which gives you pregnancy and lactation. And then they do a good job at saying like likely effective in hyperlipidemia, possibly effective for dyslipidemia or MI, and then possibly ineffective, and then insufficient reliable evidence to rate. So they do a good job at breaking down all the different studies, and then they include all of the study citations within natural products. So this is a great one to use for natural products you're not familiar with. Last one I'll talk about is then Consumer Lab. So if I'm still logged in, I am not. You can go to Consumer Lab. It looks like this. You search for a product, and they do product reviews on many different supplements. So a lot of you guys had patients who were on vision multivitamins. So I just searched for vision vitamins right here. And there is seriously like the longest write-up I've ever seen for vitamins. But they give you a quick summary of why they're used, macular degeneration, what the products are that they need, which is lutein and zeaxanthin, and then what the dose is suggested based on studies. And then they go through and they give these top picks. So I wonder if I click on this, will it take me to their top picks? Dang, I gotta sign in again. Hang on. So they do a pretty good job of, all right, I'm in. Let's go to vision supplements. If you scroll down to, I'm gonna click on this table of contents, go to their top picks. They go through the formulas and then they give you their top picks. So a lot of people had Preservision eye drops, the Areds meds, Cysteine eye caps. So those are their top 3 picks. And then they go through exactly why. They basically say, they go through each of the types. Of the 2, Bausch and Lomb is less expensive. It costs 37 cents per day for 2 gel caps versus 67 cents per day for 2 chewables of the Cysteine. So, they do a pretty good extensive review. They also do really cool things like up here, they evaluated the cost per 10 milligrams of lutein in each of the different formulations, which I thought was pretty cool. So Consumer Lab is a good place to go. If patients are asking for, do you have a recommendation on a product? You can get a good kind of review of different herbal supplements, vitamins and minerals, etc. So that's another good reference that you might want to think about using. Okay, this was a little bit longer than I expected it to be. Hey, I'm back. But I think it was good because it gave you a comparison of Micromedix and Lexi. So I hope it was helpful. I hope it helped you think through maybe how you make decisions and what your risk tolerance is for different drug interactions. So that's it. I'm really hoping this is recorded.